Fair warning.
Yes. Well, welcome back, everybody. And I understand you all have been doing your homework, so I'm really excited to hear what you've been working on. So this is our third in a series of webinars, and I am just going to see if I can get it to go forward. There we go. So this one we're going to talk about workflow, work plans, and making sure it actually works for you. So we'll get into some of the funding pieces, and we'll get into some of the details about making sure everybody's on the same page. And as always, lots of time for questions. And hopefully you are seeing my screen, and hopefully you are also hearing me. If that changes, let me know. So I won't go through our series objective because we are just, the big underlying theme is to just help make the connection for you with health systems and to increase your comfort level and ability to connect in delivering these programs. So we want to make sure that we have helped define LifeSpan's role in this work, and that that is something that you are comfortable with. And to do that, we went through in webinar 1 a lot of definitions and a lot of overviews of how these connections get made. In webinar number 2, we talked about referral systems, what the practice needs, different ways to approach things, and we went through some forms, and we have some additional forms that I believe you were sent this time, and we'll just make sure you have everything you need, or if there's anything else I can send you. And I wanted to just take a couple of minutes and hear what happened with your homework. I mean, Joyce has let me know some of the talking and some of the things that have come around in terms of identifying some potential partners. But would somebody like to share what they've been working on?
I've already talked. This is you guys.
Tika, I know you've got a plan.
Yeah, I'm working on the cost, so we can just kind of get a rough estimate of, you know, getting the education and getting the stuff aligned for the program. So
okay,
that's my plan.
Well, I have one piece in today's presentation a little further along that will talk with you a little bit about how we break down those costs. And I can share more of that information with you offline, so you can kind of cost it out, whether it's less expensive to come here for training or go there for training, and you know, some of the pieces and parts we use when we come up with costs for classes. So on top of the training piece. So happy to share that. Okay. What's everybody else been working on? Okay.
Are like intelligent talk usually.
Okay. They're all busy eating candy. That's what's going on. Hopefully, if I won't make you answer, but hopefully you've had a chance to kind of think about what your role might be, and if there are pieces and parts that still need to come to fruition, and if there's anything that we can talk about or do within the webinar today or after the webinar, we'll be happy to do that. So today what we're going to do is talk some more about targeting appropriate partners and how those general referrals can work, but also how the workflow works and what you all need to be aware of in terms of your role in establishing really successful partnerships and a successful workflow. And we'll go over some process work and some pieces and parts, and then just talk in general about what you all want to do in the next 3 to 6 months. So that's the plan for today. And again, we're going to look at it from several different viewpoints, not only from LifeSpan, but from the point of view of what a health practice or a health system might need, and in terms of what any community partners that you may be working with in terms of developing classes, training, delivering classes, what those different relationships might need to look like. So that's the plan. So I know that one of the things that Joyce had shared with me is that you guys have identified some really good possible partners. And so if you would, talk me through a little bit about what you're thinking about these partnerships. And we actually have 2 pages of them here. I added a couple, private payers and public payers. But we've got Kettering, Premier, TriHealth, and Westchester UC. So would you talk me through why you're thinking these would potentially be good partners? You don't have to give me great detail, but I want to just be able to reference back as we're working through the rest of the webinar today. So can somebody tell me what you're thinking about these guys?
Okay, I guess everybody's afraid to talk today.
I know, it's very, I'm so scary, that's why.
Yeah, these are all hospital systems, and they all have physician practices associated with them.
Great.
So it just made sense to start with that.
Good.
All right, I thought I saw the Scripps Gerontology Center on there, so that's more of a research center.
Yeah. On
the second page, but yeah.
Oh, I'm sorry, I'm having trouble hearing that one.
I'm sorry, I'm way back, Lindsay. I'm way back in the room.
Oh, hi there.
I just mentioned that most of them are providers, but there's one that is a research center for older adults, the Scripps Gerontology Center.
Perfect.
And along with that, just having contacts in certain areas in the agency. Certain people have certain contacts with those agents.
Wonderful. Well, and the nice thing about being having connections that are either on your board or you're active with their board is that you can have the discussion at a very high level and get buy-in at the high level and have an entry into the work that you're going to want to do actually at the patient level and the clinic level. So it's very helpful to get buy-in on multiple levels. Part of what we have learned the hard way, I will say, is that just approaching it by walking into a practice, you know, a family clinic that's connected to a teaching hospital, just working at the practice level doesn't get the buy-in from the top. And you really need the buy-in from the top, even though they're not going to be the ones doing the referring at the ground level. But both pieces really have to be in place and in alignment before you can see an ongoing relationship. Otherwise, it becomes very hit and miss, whether it's just that you have the buy-in from the board member and not from the practice level, or the practice level and not the board level. So it's very helpful to have both. The other thing that's really nice about, especially if you have research pieces within these, is that one of the questions that I know you all have is, how do you show return on investment? And while we're going to talk a little bit about that, one of the best ways to do that is to have a partner that is willing to look at that with you on a small scale. So they may not be willing to, say, Kettering may not be willing to take a look at utilization across the state, but they may be willing and able to look at utilization within their own practice because they already have access to those records. They don't necessarily need to get any special agreement from patients to be able to take a look at their own patient utilization and cost. So that if you work a small arrangement with them, a small study if you will, so that you will provide something for them, say classes, they in turn would provide information for you on utilization and cost savings. That then gives you something that you can use when talking with any other health system to be able to say, well, at Kettering, here's what they found. And we've had some success doing that. We have some that are in progress right now. The trick is on setting up all so many of them have to be longitudinal in terms and have to have 3 to 5 years worth of data and evaluation before you get anything back. That's what we're finding when we're working with the Medicaid or the Medicare systems in Colorado. So that gives us 5 years before we have anything to talk about. So in working with small practices or smaller health systems, where we can say, we saw patient activation scores that went from this level to this level, and what the health system is telling us is that this equates to them in this kind of cost saving, we're able to make a good case for return on investment. Anything else you want to say about these partners? First, I would ask you, which ones are you going to work with first?
In my opinion, it's Primary Health Solutions. We've already approached them. Can you hear me, Lindsay?
Yes, I can. Great, thanks.
Yeah, Primary Health Solutions, we've already had a conversation with them. They've got about 8 to 12 physicians and some nurse practitioners. They really see the value in this and are, ready and willing to sit down and already start having conversations.
Wonderful. Wonderful. And so great. And what I would suggest is I would approach as many of these as you can up front, because every one of them will have a different timetable of when they're going to be ready to actually work with you on implementing. So unless you feel like Primary Care Solutions, if they move ahead, they're going to take all of your bandwidth, I would suggest start conversations with as many as you can, just so each one will pop at a different time. In terms of Primary Health Solutions, are they talking to you about you helping them to embed the program? Are they talking about providing referrals to you so that you can then get their patients in classes? Or have you gotten that far with the conversation yet?
Yeah, probably more the second. I think they're talking about being a part of this from a partner standpoint, but they want to refer folks. I mean, they don't want to do this themselves. They just know that it needs to be done, and they like that we should be doing it. So
great, wonderful. Well, congratulations. Well, so we're going to keep referencing them back as we go through this today, and wonderful. That's very good news. And just some news on private payers, public payers. I have been in touch and have reached out to a contact person at Anthem for their WellPoint book of business in Ohio, and I'm hoping to be able to connect you with them. What we are doing and what they have available is the WellPoint book of business is the piece of Anthem business that is all about practice transformation work, payment reform, and they have set aside funding that is at the discretion of the individual markets, the individual states. So Ohio has some funding available to work with this kind of a project, connecting practices to resources in the community. And what I'm trying to do is connect you with the people involved and to find out whether they have already committed the funds for this year. If they have not, then we might be able to really have a very fun conversation about how their funding could be leveraged with LifeSpan to help fund and expand the program quickly. Plus, it gets you in the position of being able to talk about the work you're doing with Anthem, which is always a fun way to do it. So we're just starting that conversation, and I'm pretending like I didn't realize that this was being taped. So hopefully we will be able to pull that together. If not with Anthem, she said. With that we will try and hook up. Again, these are small projects compared with what you think of when you think of an Anthem or a United or a Kaiser. They're small projects, but they're a way to demonstrate what is possible, and then from there it scales up. So we're working on that one. In terms of public payers, the Medicare and the Medicaid system, I'm hoping next week I go out to a conference in Chicago, which is actually how I met Joyce last year, and we always get great updates about what's happening through CMS and what they're thinking of in terms of funding, of reimbursement, of codes for payment. So I'm hoping to have more of that to share next week. So here's what I brought you today in terms of other partnerships that you might want to take a look at. And these are links which the first one on the top is Health Teamworks. And I put them first just because they have been so pivotal to the work that we've done in practice transformation. They work in different pockets throughout the country based on what funding is available, what initiatives are available. Health Teamworks, we went into practices with them and helped practices do rapid improvement activities around self-management support, around setting up referral systems. And so we have loved working with them, and that has been a relationship that's been going since 2008. TransferMed is sort of they were the front runners. They were the first people talking about practice transformation and talking about self-management and coaching practices and physicians around self-management. Transformcoach.org is also connected to TransferMed, and right below that is NACHC, which is the National Association of Community Health Centers. I put that there because that is the inroad to the community health centers, federally qualified health centers, safety net clinics. Usually any information they have on funding, state initiatives, conferences that are coming up is all located at CHC. Part of the work that we've done with the Colorado Community Health Network has been to work with each of the safety net clinics and community health centers within the state of Colorado. In Colorado, it was a real push for all of the community health centers to become patient-centered medical homes, which gave us the ability to work with CCHN on talking about self-management support within the practice setting, and as a byproduct of that were the classes. And so for us, it was a great way to have a lot of time with the practice to talk about what this kind of a program brings to the practice, and also how to make the connection in terms of referrals and how to establish an ongoing relationship with patients. Part of what has happened in Colorado is because of the work we've been doing with the exchanges is we now have 750,000 people who have insurance now and are going through the process of connecting to a community health center, connecting to primary care for the first time. And most of those people have no understanding of how a health system works or what part of it is their responsibility, how they can be an active member in their own health care as opposed to condition might be. So to be able to work with the practices and then work with those patients that are now newly able to access services has been great for us. I also put down here the NCQA and the recognition page. And the reason for both of those is that the NCQA is still pretty much the gold standard of accreditation, and that's the one we spend a lot of time talking about. But all of those are good resources for what's going on where. This is just the Health Teamworks page. This is TransferMed, and when you go to the website, this is where you start out. It talks a lot about all of their services. And again, what I would suggest is this is a great way to see who is working within your backyard, and also to see how they are phrasing, what jargon they're using for how they're doing their work. So you will notice here that they talk about care management, care coordination, but they also talk about practice-based team care. There's also talk about connecting and access to care and information. And so all of those are places that you can connect with the coaches and find common ground. This one is from URAC, and they are actually another agency that is an accreditation agency. They work a lot with health plans, they work with hospitals, and the reason I have them here is that they are just another option for partnership and for the ability to go into a relationship in a coaching sense. It is much easier to go into a new practice if you don't know somebody, to go in with a coach who already has an established relationship and that they are paying to have come in and talk with them. So this is URAC's Patient-Centered Medical Home summary. You know, we talked about the NCQA standards. I just put this up just as a reference point. Theirs is set up very differently. It is not the only other accreditation mechanism, but it's one that is it's one of the larger ones. And if you'll notice at the very bottom here, self-management support is right there, as is self-management of chronic conditions. And so all of this, again, is just another opportunity for if you're talking with a practice and they are not doing NCQA, but they say they are working with self-managed or they are working with practice transformation, just know that whatever way they're looking at doing it, there is a huge push towards self-management and access. This is the NCQA website, and this is their recognition directory. And what's nice about this is it's a really fast way to pull up within your state everyone who is received recommendation or has indicated that they are in the process of applying for recognition through NCQA. And so it's a good way to see who is having conversations that you can be a part of. And again, that's just the NCQA site. So in terms of really talking about partnerships, additional things that are out there, wanted to just mention state medical associations, talked about the community health centers, talked about checking for practices that are recognized, and you guys have already skipped ahead on this one in terms of talking with board members, partners, health systems. The other two sites I would suggest would be the NCOA site, which is, I sent Joyce this morning the link for an online resource for the chronic disease self-management program. And they also have a lot of other information that we'll talk about, and the Centers for Disease Control as well. This is actually the Ohio Academy of Family Physicians page. And I was poking around looking for who was doing work in practice transformation in Ohio, and came upon this page. And what's nice about this is not only is the Academy of Family Physicians talking a lot about patient-centered medical home, but they reference the work that they are doing with TransferMed. So apparently TransferMed is doing a lot of work in conjunction, probably contractually, with Ohio. So I would suggest that would be a really good place to talk. And so these are just a couple of the pages that are from that website. And you'll see down here some of the other resources we've already talked about, like the NCQA site and the Patient-Centered Primary Care Collaborative. So there are some common pieces in here, but you'll see that there's also an AAFP website reference in terms of the patient-centered work, and down there's the Joint Commission work. So there is, again, common ground on this website, and would give you some talking points when working with TransferMed and getting in the door with additional practices. So what can LifeSpan bring to the conversation? Just wanted to review a little bit of what you are going to have in place that you can talk about with all these folks. One is that you will have a network of leaders. Now, I said statewide there. maybe not statewide quite yet, but you will have leaders that are trained. You will have people who can work with organizations and practices on referrals. You're going to have a mechanism for tracking referrals and communication. You're going to have a way to collect data. That doesn't necessarily mean you have to be the one evaluating the data, but it can be a common collection point. In which case that may be just as simple as everyone sends their paperwork here. It could be as advanced as you have an arrangement with one of your partners who does the evaluation work. It could be that what you want to do with the data is just how we do it here, which is collect it, de-identify it, and then provide reports back to all of our partnering organizations on demographics for their particular classes and community partnerships, as opposed to everything else that's going on under our license throughout the state. So you can do this in a couple of different levels and ways, but that's definitely a possibility. And then you, after our work and after what you all are doing as your homework, will have a number of different messaging tips and techniques that you can share with the practices and with your partners. So I think that's a lot to bring to the table. And I wanted to share with you just a little bit, if I can get my screen to change. There we go. Some of the lessons learned, and anytime I can stop you from hitting your head against a wall, I think it's a really valuable service. So I want to just hit a couple of these. We've talked about some of them before. The idea of, as you're working with partnerships, especially new partnerships on this, and you're sort of getting comfortable with the idea of referral systems and taking that patient that someone is referring and helping them become an enrollment in a program, there are some pieces that are very helpful. One we talked about before, which is a care compact. That can also be just an MOU or a collaborative agreement. But I would strongly encourage you to, in some way, to spend the time to spell out who's going to do what, just so you have the same expectations and so there are no surprises. We also determined that having a contact person, one contact person on the ground at the practice level is really important. Having buy-in at the administrative level is terrific. Having physician buy-in is terrific. But you need a contact person at the practice who is going to be the one that you can easily reach out to and say, we haven't seen your referral, or I have a question about this latest referral, or I need to send back information on the referrals that you've given me so far. So you need someone who can be that contact person for you and then can get you or get those messages into the providers and the practice management and wherever else it needs to go. When we first started doing this work, frequently the person who was our primary contact was somebody who had voiced interest in being involved in self-management. But they weren't necessarily anybody that had what I like to call the juice to be able to go to the administration or to go to a physician and say, you said you were going to do referrals and you're not, and so how do I help get you to do that? So we needed somebody who had the ability to work their way up and through the system at the practice. And sometimes the new medical assistant who has a lot of energy is the perfect person to do that because it gives them a role in practice transformation that's very concrete and doable, and they're well regarded and they have the ability to approach different administrators and get things done. Other times that is not the case. And so you have a very nice but very ineffective person as your contact person. So I would just say whatever contact person it is, you want to make sure they have the juice to get you the information that you need and that they understand that this is a priority, not just something that has to kind of fall off the bottom of their to-do list. And I will tell you that we have had amazing relationships with people who are practice managers, physician owners, medical assistants, front office people with absolutely no training in self-management support that become cheerleaders and champions for us. So it isn't so much the title as it is that person's place within the organization. And so that's all I'll have to say about that. In terms of referral logs and follow-up, one of the other things that we've learned is to ask how frequently they want that information back. We do a lot of work with Kaiser Permanente, and they don't want to see referral logs more than every couple of months. We have other practices that they want to see what's happening on a week-to-week basis. So it really depends, again, on the practice and the health system. So next one down here is patient panel versus patient referral. So we talked about the fact that one of the selling points for this is that as practices are going through their transformation work, they're taking a look at a patient panel and what is the best they can do for that group of patients. So for example, it might be a patient panel of everyone with diabetes. And so they, as a practice, are going to set up the evidence-based criteria and say, well, for this panel of patients, for this group of patients with diabetes, we want to make sure we are doing the following things. And so it'll be things like foot checkups and what medications they're going to check and at what point, and what they're going to do when A1C hits this level versus when A1C hits a different level. So they will have all of those pieces and parts in place, and it's a perfect time for them to say, one of the things we're going to do with this patient panel is everyone who falls within these parameters, we're going to refer to a program. Well, that's fantastic, and that's a great way to get what you want to do as a service really embedded from the practice's thinking. What we determined, though, was not helpful was when the practices would send us the whole panel of patients. So we had some very well-meaning practices, and we were very excited when they sent us over in a nice HIPAA-compliant format 500 of their patients. The problem was what we got was a list of 500 patients, none of whom had heard anything about what we were doing from their healthcare system or provider. So in essence, we were cold calling, but instead of calling with storm windows or whatever else people, timeshare plans, what we were calling for was self-management of your chronic condition. And as you might expect, we got very bad results from doing this work. And we really confused a lot of patients. We tried, but it did not work. So now so rather than just working at it that way, the patient panel is a terrific way for the practice to identify which patients they may want to concentrate on first for a referral. And you still want the practice to talk with the patient about what it is we're going to be doing. So within some practices, that means they want a signed form that the patient signs that it's okay for us to call and enroll them. For other practices, like the practice that sent us their entire patient panel, they considered the fact that this was a continuation of their services to their patients as implied consent. And so they felt comfortable sending us the whole patient panel. It's really kind of up to the practice and how they look at HIPAA and how they protect that health information. But I will say having the difference between calling someone who knows you're going to call them and calling someone out of the blue is night and day. And so the readiness assessments we're going to take a look at in just a minute. And the other piece I wanted to just mention is this whole idea of yes and messaging, especially because I know you all are just getting started. What tends to happen is if you're talking with a practice or a health system and they say, how soon can you start? How long do we have to wait for classes? You say you can do classes for our patients. How long do we have to wait? And one of the things that we discovered was that if we said, well, it will take us 6 to 8 weeks to get a class set up in your practice, for the practice, that sounded like forever. Now, for those of us who are setting things up, we realize by the time we have leaders and by the time they start referring and by the time we get a class filled, it may take 6 to 8 weeks. But if we set it that way, well, it'll take 6 to 8 weeks. What happened was the providers heard, I don't have to do anything for 6 to 8 weeks because it's that far away before we have a class, which meant that 6 to 8 weeks later, we were still trying to get referrals because the providers had heard it was happening way down the road. So what we discovered is we needed to say, yes, we can start working right away on getting a class for you. We can start working on that today. Here's what you need to do to help. Here's the referral form. So that what they heard was, yes, we're starting right away. Yes, I need to be paying attention and start working on this. And they're starting to work too. Now the reality of it is pretty much the same. It may be 6 weeks before there's a class for their patients, but we don't want anyone waiting for that period. So it's a very simple difference in terms of messaging, but it has proved to be very, very, very helpful. So I share that lesson learned. Any questions about any of this stuff so far?
No. I have a question
Okay.
about
So
There is one.
yeah, when you have a group and you've made a commitment of 10 people to come to the class, go through with that class. You know, like.
Oh, you mean in terms of if you say, we'll do a class if you have 10 people?
Yeah, and
What's
then.
their incentive?
Yeah, and like, or 2 people show up, or I mean, I was thinking like when you get you're set up and you got your trainers and.
Well, that's another reason to go with the idea of you helping to handle their referrals and enroll them, because it's very easy for them to say, oh, I've talked with all my patients, and so I know we have a group showing up. But if you don't know who it is that's planning on attending and you haven't been able to confirm with them, then you don't know they're going to show up. And one of the things that we have learned is when we've worked with a practice, for example, that says, oh, we can do this all ourselves, we'll have it all set, we'll do it, all you have to do is show up. We frequently find that's what happens, is that they don't necessarily have a mechanism in place to enroll people in a class. In the same way that if you're doing services through LifeSpan, you need to have a commitment and an enrollment, if you will, from a person who's going to participate in anything that you're doing. So you need to know who it is that's planning on attending so you can make sure and confirm participation. Now, sometimes the practices will work with you and give you a list of people they have enrolled, so you know they have talked with these 12 people and these 10 people have made a firm commitment they're going to be there. What usually happens, though, is that it's not handled as much like an enrollment as you would like it to be. And so I think part of what you just need to spell out with them is we want to make sure that we're getting the message across to your patients in the best possible way. So let us help confirm those calls or work with them and coach them on how that needs to happen. Now, we do have practices that have started with the idea that their staff is going to do the classes, they're going to do everything internally, and they're going to promote internally, and then they're just going to wait to see who shows up for the classes, thinking that that would show a level of activation that would ensure that they would be really responsible in the classes. The feedback we hear from the practices, though, is that it doesn't work. And the reason it doesn't work is that the people that they want in the classes are not necessarily the people who are activated enough that they're going to understand why this is important. So again, it's about the messaging that you can help with and the teaching moments, if you will, to be able to share with the clinic staff that you want to be able to make it very successful experience for everybody involved, especially the patient. So it is in the clinic's best interest to let you assist them with this part of the process. And then the bottom line is, if they are saying they want your class and they want you to do this, whoever's making the dollar commitment, if they say we will do this and they can only show you they have 2 people signed up for a class, then it is well within your discretion, I would think, to say we can't do a class for 2 people. We must have, this is our agreement, we have to have this many people in class. You know, and things happen, and sometimes it snows, and sometimes people don't make it to class, or whatever. But I think you're bringing to them a real service, whether what you're doing is just helping them to connect the dots or whether you're providing them with the class. Whatever that is, it's a real service. And so what their incentive is that if they want this service and they want their patients in the service, this is what they would need to commit to. Is that fair?
Yes, thank you.
And I think part of that is that's part of what has to be spelled out with the clinic, with the health system, whoever it is you're talking with. So this is a collaborative agreement that we did with our statewide chronic disease program. This is, we have 17 different license holders in the state of Colorado, and we were trying to bring us all sort of together so that we were not all going 17 different directions, so that we could share some best practices and some fidelity concerns, and we could make sure everybody was training in a similar way and sharing materials and sharing leaders as needed. And so this is a collaborative agreement that we put together. I stuck this in just because it may be that as you are moving through this, you will find yourself in need of some sort of collaborative agreement with other license holders in Ohio. And so just a suggestion that that is a nice template, and feel free to borrow it. This is the care compact, and you were just asking about what to do if a practice, what's the practice's incentive for actually having their patients go in. And this care compact, actually, we got out of the Medical Home Initiative and our work with Health Teamwork. But this is the kind of agreement where you would spell all that out. We'll do this for you, but here's what we need from you. And so they're used to doing this kind of agreement, as you are, and so this just puts this kind of work at that same level. So we're back to time and money again. I love this because I feel like this sometimes. I don't know if you do. But what we want to do is return to the idea of what you have to offer is a way for people to save time and save money within the practice, as well as really helping people within the process. So I wanted to talk about pricing and partnership. And one of the things we have learned is, unfortunately, there is no one way all of this works. So we find, and I shared this with Joyce earlier, we find that when we are doing classes, especially with new partners, we call to demonstrate the effectiveness and demonstrate how we would work with a partner before we get too concerned about sustainability with that partner, or even scalability, if you will. So frequently it requires you demonstrate on a small scale what's possible, maybe with one class, to show them how the workflow on their end would work, so that you all get a sense of how the workflow together works, how the partnership works, what the possibilities are while you're looking for and crafting how you're going to do a partnership on a larger scale, and how the funding is going to work on a larger scale. So again, what we do is cobble these together, and I'll give you a couple of examples in a minute. The other thing that I wanted to mention in this is that while the national payment models are in process, while CMS is looking at what Medicare is going to do and what Medicaid is going to do, they are still funding short-term efforts to embed self-management programs nationally. There's another set of funding that's coming up that we understand is going to be announced April 1st and will be a continuation of funding through the Older Americans Act. So it's really geared toward those over 60 and 18-year-olds with disabilities, but others under that age group can also be participants in the class. It just needs to be, the majority of folks need to be those who are over 60 or with a disability. So there are funding things that are happening nationally to help support implementing and embedding these programs until the big changes happen with, hopefully, national payment models. So as we're going through this, a lot of this is here's how we do it today, and still the light at the end of the tunnel is some payment models on a national basis. So this is one of the things, one of the little forms that we use to determine how we're going to pay for any workshop series. This one is, you have a copy of this. This very simply helps us figure out who's going to pay for what. And because each of the partners that we work with, we have a different funding cycle, and we have different funding that it may work with. So we may have a contract with Health Teamworks that says we will provide the coaching assistance, the referrals, the enrollment work, all of the work at the practice in terms of getting the referrals made, but we don't have the cost of the class covered. And we may have a different set of grant funding that actually will pay for the participants in the class, or will pay for some of the participants in the class. So what we end up doing is every time we're starting a new partnership or a new overall series of workshops, we work through this little, this game board, if you will, on who's going to do what and who's responsible. And then we're able to match that against what funding we have in place. And again, with COA, we're in an unusual position compared with, say, an area agency on aging. So I imagine LifeSpan is going to be closer to how we are able to do this in that there, as a nonprofit, we have the ability to contract, we have the ability to fundraise, we also have the ability to receive grant funding. So we tend to put all of those together and work it that way. Just to give you another breakdown of this, this is just a sample percentage sheet that we came up with to take a look at what we within COA were spending in terms of the items that we were doing for any class we did, and what percentage of the funding actually went to those particular line items. And we did that just because we wanted to have a quick and easy way to say, we're going to be doing everything except snacks. So how do we figure how we're going to charge, and how do we figure we're going to recoup costs? So if we're taking on 95% and our partner says they'll take on 5%, what does that look like? If it's something, sometimes it comes out very much 50-50, and that makes it easy. Sometimes we're doing very little, except we're doing the licensing and we're doing the data collection. That then means, from our point of view, we need very little income from that class in order to make it work. So we set up this little system just because it, for us, tells us what percentages we use. And you'll see that this also includes recruiting assistance and referral processing and enrollment. So those two pieces together are about 18%. So if you look at those two percentages and the data collection piece, that's about 20%, and that's what we figure the cost as we price out a class, 20% of that is the costs are for us to work with the practice, work with the referrals and the enrollments, and collect the data. Okay, and then I put some notes in red because we in Colorado, some of the grants that we've been working on, the grant pieces, not the contract pieces, but the grant pieces, are paid on how many people complete the class, not how many people start the class. And it's paid on a per completer basis. So if, for example, to go back to what you, the question earlier about how do you get someone to commit more than 2 people in a class, we have to look at it not only from the fact that a 2-person class is not usually within the guidelines for an effective class size, but if we're only being paid for 2 people within a class, that means that we have made far too much of an investment for those 2 people. There's no way to recoup the cost. Now, we may be able to do that once, but we certainly can't do that on an ongoing basis. So we have to take a look at that. And especially for practices that are interested in return on investments, they will understand those. They'll understand that conversation. One of the other pieces that we look at is, are we doing simple data collection, meaning the standard data collection that would be demographics and maybe satisfaction levels, or is the work that we're doing within this series of classes on a specific research project? So we have done translational research for the Cancer Thriving and Surviving curriculum. We're doing some translational research now with a new additional week of the workshop series that is around leisure activities and identifying what it is you really like to do, and then making sure that you're able to build that into your day and into your self-management process so that you are really getting the most enjoyment out of your life. So we're in the process of doing the class research for that. We're also doing some research around Imbalance, which is a falls prevention program. And so when we do that kind of data collection, that is a very specific research project, and that 2% goes way up. It sometimes means that we have to have also evaluation in the budget. And usually if it's an evaluation and a research situation, it's either a contract or a specific grant, and we've written those costs into it, but not always. So we just have learned we need to double check ourselves on that. So I want to switch back just real quickly in terms of messaging and talk, before we get back into the money, just about the idea that there are, we mentioned this before, there are activation and readiness levels that people talk about for patients and for just people. Are we ready to make changes? Are we not? At what of the 5 stages of readiness are we at for really being an activated patient? But the same is true with a health system, and within a health system, it's true within each and every practice. They are at a different level. And it's also true with any of the organizations that you're going to be looking at partnering with. Everybody's at a different level. And you are at a different level now than you were 6 months ago, and you're at a different level than you will be 2 months or 4 months from now. So it's a matter of understanding that everybody is playing at a different level, and just making sure that you are matching your message and what you need for the partnership or the relationship, so that you're acknowledging that you and your partners may be at different levels. Second point is to stay shiny. And the shiny bauble syndrome is very prevalent within not only nonprofits, but it's also very prevalent within practices. And what I mean by that is the idea that whoever comes in the door with an idea is the shiny bauble of the moment. And you can think you have made a great deal of progress in partnering and in getting buy-in and finding a champion, only to find that the shininess wears off very quickly, and the next person who goes in will have a similar reaction, and they are now the shiny bauble. So part of the trick is not only to establish a relationship and to be in front of a practice and in front of a partner once, but to stay involved with them so that you stay shiny, so that they are understanding that not only are you bringing them something, but that they're getting something out of it, and to keep reminding them what they're getting out of it and what their patients are getting out of it. So we came up with some messaging and some scripting that we have shared with the practice so that we can keep that messaging in front of them, so that we can remind them how important we are. And not just we meaning COA, but we meaning the chronic disease program and whichever of our partners that are delivering the classes. And part of that includes how to recommend and refer the classes. What are the basics of setting up a goal with a patient? As we mentioned, a self-management goal is one of the requirements now for patient charting. Well, how to set up a quick, meaningful goal with a patient is an art form that we can help teach a practice. So how we can help stay in front of them is how we make sure that we get enough buy-in to be able to do the work together we want to do. This is one of the pieces that we used to do this. We are just starting them again in English and Spanish, and we did these on a monthly basis. And they were just a self-management tip of the month, self-management goals, practices. I saw this one just last week. It went out in 2013, I think this one was, and it's still up in the practices. It's designed to get patients and staff thinking about what all a self-management goal might be, that it isn't necessarily I'm going to lose weight or I'm going to quit smoking, but it may be I'm going to drink less soda or I'm going to call and make a dental appointment. So we provide that as another way of messaging and keeping in front of things. We do some quick messaging with the providers. I'm going to recommend you exercise a little bit more. And I know you don't believe me that it's going to help your pain level, but I want you just to try it. Or I'm going to refer you to a program that's going to help you manage your COPD and help you feel better. It's called the Chronic Disease Program. I'm making a referral. They're going to call you and get you enrolled in a class. And then this one was one that was suggested by a physician. We're a team. We can do a great deal medically to help you manage this, but there are pieces you need to be doing for yourself. And so I'm going to refer you to a program that's going to help you with those tools. So giving these as a script has been very helpful and important. Providing some just basic tools for the practice. I saw this one yesterday, as a matter of fact, with handwritten in updates of when the classes are. And just these actually end up being in exam rooms, in bathrooms, on front windows in the practice. And although they are great at getting the name of the program in front of people, it's rare that someone is going to see this and say, oh yeah, that's me. I have a chronic condition. That's me. I need to be in this class. But it helps reinforce the message when the provider or the medical assistant talks about a referral. Same thing is true with brochures. I think I mentioned that earlier, that I have this pet peeve about people thinking handing a patient as a brochure is the same thing as a referral. And they're great at reinforcing the message. They're not so great at being the whole message. One of the other things that I would suggest and that we have found helpful when we are approaching a practice for the first couple of conversations is to talk about a PDSA cycle, the Plan, Do, Study, Act. Is that is that wording that you all are familiar with? There are all sorts of different versions of it.
Yeah.
Yeah, okay. one of the reasons we like it as a nonprofit is that it works like we do, which is you try it and then you figure out what you need to correct or tweak, and then you keep going, as opposed to some of our partners in the research field that have to do a lot of studying before they can actually start doing the work. And so we like being able to, let's try it, let's see how it's going to work together, and then we can course correct. So, so the PDSA cycle has been very helpful. The other piece that I think is good to talk with conversationally with the people you're talking with is think back on the list of interested partners that we went over in the beginning. Is what is their goal? Is their goal to reach a certain number of their patients? Is their goal to eventually be able to embed and to own this kind of a program themselves? Is it something that they want to just try because they have some grant dollars and this is something they want to spend the money on? Or is it something that they really want to sustain in the long term? And then to be able to take a look at, in terms of the curriculum itself, do you want to stay, you meaning LifeSpan, to stay as the organization that is providing all of the training in that curriculum? Do you want that to be your role, or do you want to introduce them to the curriculums and then help them embed it? And how much do you want to get involved in workforce development training? I mean, with all the different product lines that you all have within LifeSpan, I would think that doing workforce development might be a real extension of your sustainability and your overall marketing, because you can talk about, we do this, oh, by the way, we also do these other 20 things. So that may be something that you'll want to address a little bit as well. So I just threw in a couple of these, and I'm happy to send these to you electronically too. We got asked when we were doing some workflow development to come up with pieces about what self-management support the folks at the front office and the medical assistants could do. Whose job was it to make a referral? Whose job was it to talk about self-management with patients? And it was a great process we went through with the practice, and it was also a great process to go through with the medical assistants, so that they started understanding that they could make the most of any interaction with a patient. And so we came up with these do's and don'ts. The do-nots include, don't talk about medications, don't talk about what kind of diet someone should be on, don't tell them what kind of vitamins you take. Those are inappropriate things for a medical assistant to be telling a patient. But what was appropriate was to understand that just because the patient was not wanting to talk about making changes or doing something different did not mean that they were never going to make a change. It meant that at this moment in time, they could not understand how their actions related to how they were feeling. And so when we talk about when's the moment that you can make a change, no one knows. So if everyone who's interacting with the patient makes the assumption that this may be the moment that they will be open to making a change, owning their own conditions, being ready to talk about self-management, being ready for a class or a change, if everyone makes that assumption, then you have a whole series of positive interactions that then result in LifeSpan having people in classes. So in terms of making your case, there are the workflow pieces that we mentioned, Care Compact or an MOU, the referral pieces we've talked about, and then there are just some simple reports and things that we can provide. This is the same squirrel we started with, and I just want to go back to it because we've talked a lot about how the referral process works. And perhaps one of the steps that is the tricky one is how you get to the point that you are actually meeting with the clinic. And you all have demonstrated from what you've shared with me is you already have some really good inroads there. And so what you take to this meeting and how you proceed is it's totally up to you and the relationships you have with them. But I want to suggest just a couple of things you might want to take with you. And one of them is a version of this kind of a process to be able to show them that here's the pieces and parts we will do, and here's how this interacts with your system. So I think that to change it around or do your very own version. This is another one we did for our statewide collaborative, so it was not specific to COA. And this was about working with RICOs, the Regional Care Collaborative Organization, on how to enroll new Medicaid recipients into primary care practices and then have them also referred at the same time into self-management programs. This one was done a couple of years ago, and we have some ongoing work that we've been able to do with the RICOs since then. And then we've already talked about the referral systems that we have. So we mentioned the stages of readiness, and I'm not going to spend any more time on that, except that that's when it's kind of key to just have something in writing that indicates where you're at, what the plan is, and to make sure that everybody has the same plan in mind. So this is one of the checklists that I sent over, and this is one that we actually developed because one of our grantors, the State Unit on Aging, which deals with the Older Americans Act funding, was having a tough time following how we worked with the practice. And so I wanted to share this with you for a couple of reasons. One of the things is it gives you a checklist here of what the clinic has agreed to do. It also gives a checklist of what we're agreeing to do, what steps are in this process, and then what outcomes occurred. When I said earlier that it's kind of a good idea to approach all of these practices at once, the reason I said that is that they all move through these checklists in very different ways, and with changes in EHR, EMR, practice transformation work, staffing changes, workload changes, staff vacation schedules, et cetera, you can have someone who is very much engaged in the process, then they're suddenly on hold for 3 months, then they're back. And so this is a tool that we came up to track internally and to also be able to share with partners where we were in the whole process. And this little piece on the bottom is how those classes are going to be sustained. So because this form was done particularly for our work with area agencies on aging and Older Americans Act, we have those two as the very top levels of support. That is not traditionally our largest level of support. We have found that although we work with some of the AAAs very closely and some of them have their own programs and licenses, we tend to work in other areas, and they're not doing a lot of work with the practices, which is where we do most of our work. So the other funding sources that are here for us include the patient-centered medical home enhanced reimbursement dollars. Those come to us usually in the form of grants and occasionally in the form of contracts. Our contract is to provide these classes for this amount of money. Insurance is not so much, unfortunately, as I'm hoping it will be. In certain states, Medicaid is doing a lot more work. In Colorado, we're just starting to really see Medicaid dollars dedicated to determining whether this class will affect utilization and have a real true cost benefit. The work on the national level is going much faster. In terms of insurance, we also are starting to work with the Diabetes Prevention Program, and that program has reimbursement already attached to it from Anthem, from Kaiser, from United Health. So when we use the same checklist for that program, we then are looking at, does this one person who's in our class, is it being paid for through Anthem, through Kaiser, through United, or is it under one of our contracts otherwise? There's also private pay, donations, outside grant funding. We're training staff to lead classes, or ongoing technical support that we're going to provide. Frequently, many of these little boxes are checked. And again, it's a way for us to demonstrate not only all the different ways we cover our costs, but for us to make sure that we're always adding to this list. I had shown you the referral log, but I think that one of the things that is not in this sample, but is something that we do, is that we also track what insurance provider people have, so that we know if we are able to bill insurance, we have that capability. And with some of the projects, we're able to do that. With others, we aren't. I mentioned the work we did with Anthem, and we were very fortunate because the practices that we worked with on their behalf, we were working with the practice as a whole, not necessarily just Anthem. Feedback form, we also mentioned earlier. Again, this is something that the practices have grown to really appreciate, and they look for this. And it's one of the ways that they justify the expense of training staff, and it's one of the ways they justify the cost of referring people, taking the staff time to actually complete a referral form. Is because of what they get back here on the bottom in terms of the goal for the patient, the confidence level, and the increased communication efforts. So I want to give you just a couple of snapshots of some of the practices that we have worked with now, and what it looks like, and how they all flow together. So this one is University Family Medicine, which is part of the University of Colorado Health System, and we now have classes running at 4 practice sites. There are 2 more that our Director of Implementation has met with, and they are going to be adding classes on site as well. Initially, we were introduced to the practices through a grant program and through a coaching. I take it back. It wasn't a grant program. It was through Health Teamworks. The very first of their family medicine practices was going through patient-centered medical home transformation. So we met them initially through a Health Teamworks event with their coach. And since then, it's about 3 years into our work with them. They have trained 6 staff people to offer the classes on site in the practices. We provide a good deal of technical support to them. We do not do the classes for them on site. They do classes specifically for their referred patients, and the folks that have trained to be leaders are also responsible for doing the follow-up and the enrollment of their patients. And we've spent a lot of technical support time with them to help them do that. We also are invited, our Director of Implementation goes to their quarterly meetings to help them problem solve. We're considered a part of the team on that. And this year, they just were awarded the Practice of the Year, the Outstanding Practice from the Colorado Academy of Family Physicians, which is an honor. And they made a point of inviting us to the celebration and made a point of saying in writing that were it not for the work they had been doing with COA and with training and embedding the chronic disease program, they would not have received the award, which was very nice to hear. Now, how we covered costs here is that we trained their staff for them. And so that is, and we, help them purchase materials, or they purchase them through us. But the primary thing that we did at this point was the staff training. This one is a program that's also been going on 6 years, close to 7 now. It is in conjunction with the YMCA. It is not a YMCA project per se. There are projects that are national YMCA supported programs with chronic disease and with diabetes prevention. This is not one of those. This is one little local Y, and its work with a community health center, federally qualified health center. They have trained 15 staff people in English and Spanish. They do direct clinic refers. We have trained those 15 staff people, and what they are doing is pre and post follow-up. They do utilization, funding checks. There is joint grant funding that runs the program from the YMCA and the Longmont Y, or the Longmont Y and Salute, excuse me. And so that is very much what we did was go in the beginning to help set up the program. We help train. We provide the fidelity checks, and we help them with the referral process. But right now, it is they are famous for teaching me that you could do a class on a Saturday afternoon at 3 o'clock. That's a story that I love to tell, because in a million years it would never occur to me to ever try and host a class at that time. But they figured out for the people they were working with that was the best time. And so what the program includes is that they wrap around the 6-week curriculum with a 12-week membership at the Y. And one of the comments we heard is that it's very easy to keep yourself engaged when you are on an exercise bike and trying to get used to exercising, and you look and 2 people down is your doctor, who's also on an exercise bike and also sweating. So this is one additional way that we have done some work. Our Healthy Lakewood project is part of our Healthy Communities work. This is a wonderful 4-month-long program that includes the chronic disease self-management program, but also includes a community health coach, and includes the City of Lakewood Recreation Center providing access and venue for classes, and also is providing incentives so that as someone completes the class, they get a $50 gift card to be used on any Lakewood recreation offering. So that can be golf lessons, that can be a pottery class, that can be dance class, that can be whatever the person wants. But this program is fully funded by the City of Lakewood. We're doing a similar program, a couple of other cities in Colorado, and one other large Healthy Summit, which is a combination of several communities over a 5-county region that are in the mountains in a very rural area. And that project, the one that's the rural project, is being funded by a combination of grant programs as well as city funding. This one is fully funded by the City of Lakewood. And this is Metro Community Provider Network. They are a community health center that has been expanding. So they went from just a couple of locations to now they have 4 huge clinic sites, including one that was just built. We have been doing this program with them officially for 4 years, and they were doing it kind of unofficially for a couple of years ahead of that. They have trained staff, and we also help. Occasionally they will use some of our staff as well and stipend them, or our leaders, I should say. They're doing the classes as bilingual classes, so we do them in Spanish and English. They are right now fully sustained, so meaning they're doing the programs on site. They've embedded the program. They have their own trained folks. accept that. They occasionally contract with us to come out and provide updates on self-management support. Was out there last year doing a staff presentation under contract on how to refer and how to enroll. And they are using now community health workers as well as medical assistants and their behavioral staff to make this work. So I promised you also another checklist in terms of practice readiness. What we started doing with our Anthem project was to do a readiness, a tool for how were people ready, was the practice ready, had they given thought to this, or to also be able to show them things had changed over the course of working with us. So we started with this great little practice readiness tool, and there are a number of different readiness tools available. This one you'll see is cited at the bottom, and I did send you a copy of that, but the McCall Center for Healthcare Innovation has one, CDC has one, Stanford has one. We sort of wrote our own and then credited the people we had borrowed from. And what we did was not only come up with this that we could talk with the practice about, but we then came up with, here's all the resources we can bring as a partner to match what may be lacking in the resource. So if someone does not yet have a reason for why they need a self-management support program, we can come in and talk about the PCMH overview. We can come in and do a presentation for them. If they are trying to understand how to make sure that they have support tools available for patients, we can also come in and bring them things like self-management support tips, food logs, exercise logs, et cetera, et cetera. And I want to leave you with this before we go to questions. This is based very loosely on Elizabeth Kubler-Ross's work on the 5 stages of grief. And what we found was some of the practices were very much feeling like this was a daunting task for them, the self-management piece. We were all excited because we had this great program and classes and a way to connect. And the practices were feeling like they weren't feeling as excited as we were. So we jokingly came up with this, but I think we can all agree to it, that the first stage is denial, and it's a practice to say, we've already given out everything there is to give. The next stage is anger. We will never be able to make this work. It means nothing. Then we can go through bargaining, and then we go through depression, and then eventually we help the practices and our partners get to acceptance. Look, we can do this. Look at the progress we made. Our patients are engaging. The referral system's working. They're coming back and sharing with us the goals and their motivation for getting better. And so I would leave you with this because I think any of these things feel a little daunting. But I would say also daunting but doable. Maybe I should put that on a pillow or something. Daunting but doable. Okay, time for you guys to let me know what it is you want to do from here over the next 3 to 6 months. And again, it has to be something you want to do that's achievable and that you can document and that you feel comfortable on a scale of 1 to 10 can be accomplished. So I would really like for you to share this and tell me kind of what you're thinking. We can also talk about questions and answers. And at the same time, I just want to let you know that we did set up another time for us all to meet, mainly not as a presentation time, but as a check-in time. And for you to share with me how it's going, ask questions, share successes, et cetera, et cetera. So where are you? How are you feeling about this?
Anybody can speak. This isn't limited to me.
No, I know, but I mean, probably one person ought to.
I heard somebody talking.
Well, we're trying to figure out who's gonna speak, Lindsay.
Oh, okay. All right.
Because we came up with this, didn't we?
Well, not really. I think obviously what we want to do is we need to finish completing our process. We need to be able to have the product to offer too. So when we build those relationships and bridge those gaps, we need to have something to offer to them. So I think that's going to be the next at least 3 months work.
Yeah.
Is get that set in place, get some of those licenses in place, and then figure out how that process is going to work internally here, because it is out of the norm for us.
Right.
So it doesn't quite fit, like, to like add it onto a program. So how do we make that work internally? Is my thought, but I don't know what everybody else is thinking.
Well, yeah, I mean, this is Emily, I'm the HR director, so I was just thinking of the items that should be addressed, like who and how are we going to, who's going to do the referral process, who's going to do the tracking and the logging, who's in charge of the communication to the providers and feedback. Obviously, we have to train staff and decide whether we want to add staff to that, or, like you said, promote and see what the response is. Do we have facilities and equipment to do it? Who maintains the relationships with the providers? And who maintains relationships? Do we maintain relationships with clients? I don't know. That's something I'm still confused about.
That is a really good question, too.
And then what exactly is our curriculum? This seems like LifeSpan is excellent at having ongoing clients and keeping them very happy and sustained. So this is something more of, we get the referral, we do a few classes, and then they're gone, right?
Well, not necessarily. Not necessarily. I will tell you there was a really active program through Northwest Colorado Visiting Nurses Association where they provided in Steamboat Springs and Craig, that area of the state, access to ongoing, they lived within a hospital. They provided access to all sorts of different programming, including this program, including the evidence-based program. But they also kept track of, they were long-term clients of the program. So once someone got referred into any part of the class structure, if they got referred into exercise or guardianship or money matters or any of the programs that they were offering, they then had access to all of them, and they could track through their system what additional classes they had taken, so that once someone came into their system, they stayed within their system. And it made it much easier for them to cross-promote all sorts of different programs. So you could take a look at doing it that way. The only thing that would be, well, that wouldn't even be tricky, but what you would need to do is just make sure that on the referral piece, providers realize that you were not going to be letting go of their patients, but that you were going to want to continue to provide access to them, and then you would just have to let the patients know that too. But that could be the beginning of a beautiful long-term relationship, and a beautiful long-term relationship with the practice, understanding that everyone they referred to any of your programs, they were referring to all of your programs.
That's a new twist. What were you thinking, Bill? Are you still fuzzy?
No. I mean, I think it's almost like you have to do one and get one under your belt, and then you can figure out how to modify it for other organizations or something like that. I mean, I kind of keep coming back to like the fall prevention thing. I mean, that to me is very clear. And so, you know, do we start like with primary health solutions and David's gone, and you know, try and structure something around the fall prevention? I don't know.
There's a lot more fall prevention classes in this area than there are the chronic disease.
Okay. Okay.
I mean, if you're looking to make a place, I don't know.
Gotcha.
Not that you can't do the fall prevention, but a lot of the senior centers are doing that. Council on Aging is doing that. I don't think they're doing it in conjunction with the practice. They're just offering them that.
I agree with Bill. I think we should pick one program, structure a class, and then kind of pick who we're, or pick the whole process, just one, the whole process from start to beginning, and figure it out, and then go from there, change, replicate.
Well, that's your whole cycle, basically. It's like, let's do it and try it.
Yeah, the whole PDSA.
Yeah.
So you figure out what you want to try, and then try it, and then see what you want to change. You know, the other possibility would be to work with leaders who are already trained, even before. Not that I don't want to see you get trained, but some of the work you could be doing before you even trained and did the program on your own. So that might be a possibility.
Is there an easy way to find those, or do you almost have to go to who's doing the training and they have to give you that access? I mean,
if you were
but how do you find? Yeah,
probably through the Stanford site would be the way to do it. And probably those folks are going to be associated with AAA.
Right.
Which may or may not be how you want to do it, depending on how much ownership you want to keep for the program and how much you don't want to keep. So it might be a way, it might be something to do, or it might not. It might be worth considering, though.
Yeah, at least explore.
Add it to your whole list, your checklist there of all the different moving pieces and parts. Because I do think you're right. Who's going to be in charge of provider relations and who's going to be doing referrals or working referrals. I would love to tell you that you will have such a slew of referral calls that you'll need to set up a whole call center, but realistically that is not the way it works. Even in a multi-provider practice, they may have 1,000 patients that they could refer to you, but it takes time for them to begin referring even a few at a time. So the referral call piece is probably not going to be as challenging as it sounds.
Makes sense.
Well, I know we are planning on another catch-up call, and I promised Joyce today I would send you the information I have on, there is a Medicare reimbursement that's connected to behavioral health, and I'm going to send that out to you because I know that's one of the areas you work in. It might be that that would be something that would help offset costs. It might not be, so I want to send it out just in case it would work for you. And the other piece that we are investigating the diagnosis, the CPT codes, the billing codes. There are several of them that are geared toward self-management that is not provider-led within practice situations. I will tell you honestly, we are looking for someone to partner with to do the work around the CPT codes because it's not something that we want to do the billing, but we're looking for an entity that is already set up to do this. So we've been working with a couple of our practices on doing this work. So far, it's been slow going because most of the practices are dealing with patients that are Medicaid or Medicare as opposed to private pay. So we haven't had anyone that could see the rationale behind doing the billing paperwork it would be necessary to bill for to bill the CPT codes. But we're working with that. So I'm going to send you some information on that as well, because that is something that we are really hoping gives us access into the private pay world. So what else can I do to be of support at this point?
I don't know. I think we just have to kind of digest it, Lindsay. Especially some of the forms and the documents you sent along. Those are good.
Oh, good, good.
Well, and you're still going to reach out or follow up with Anthem, WellPoint in Ohio, huh?
Yes, yes, I am. And I'm hoping that it's going to be a very positive interaction.
Yeah, that could be good.
Yeah. It'd be a great place to start. And, yeah.
I wonder if they're going to be at the ASA conference.
You know, they are. Some of them are, but not. It's a different group.
True. Okay.
That'll be at the conference. I will be seeing some of them in conjunction with the Patient-Centered Primary Care Collaborative, and I will be meeting with some others. I'm out in Washington for the grantee meeting. They're doing a joint falls prevention and self-management grantee meeting, and I'm going to be speaking there. And so I will get to see some of the folks out there then as well.
Okay. All right, and then I think later, or the sidebar with Tika and I, kind of about training in Colorado versus here.
Yes,
Yeah.
yes. Not that I wouldn't love to have you out here. That would be very fun. I just want to make sure we're doing what will be most expedient for you all.
Okay.
Well, okay, so the conversation does not have to end. If you think of anything that I can do to be of assistance, let me know. And we're going to be talking again in a couple of weeks. And you're going to be talking, I'm going to be listening. So, and then we can kind of take the conversation from there.
Yeah, that means we'll have to figure out when that's happening. I don't think we actually have it set, do we?
Well, I think so. Let me double check.
we?
I was thinking we had it. Let me see.
I don't have it in front of me
I'm thinking
yet.
it's April. I show April 23rd.
Maybe we do. I guess I better send out an invitation.
Yeah, and I have it as a webinar. We can do it as a webinar. We can do it as a phone call. If you want to do it as a webinar, we can share the screen so you can show me what you've been working on, or we can do it as a webinar and the way we've done these. But totally your call.
What do you guys prefer?
I
How about we figure it out?
Yeah, I don't know that we're going to be ready to do a webinar, but we can certainly talk by phone.
I just know sometimes it's nicer to actually have something to look at besides just looking at the phone with a disembodied voice with nothing.
Well, we can definitely play it by ear. That's pretty quick to set up,
yeah,
so we can
okay.
do that at the last minute if need be.
Did we set it at the same time, 2 o'clock our time?
Yeah.
Okay. Yeah, I don't have it on my calendar either.
Well,
I put the webinars down and
we can also move it.
yeah, because we've got some work to do.
Mm-hmm.
Yeah.
That's not a lot of time, but we also don't want to take forever either. So, okay.
Well, it's been a pleasure, and thank you for letting me be a part of your planning. I appreciate it.
Well, we appreciate your help. We didn't want to reinvent the wheel for sure.
Yeah.
It's like you definitely got this down pretty good.
Well, you know, every day we learn something else.
Yeah.
So it's kind of like just when you think you got it all. Information. That's what I would like to do. And this will be, you will have this in YouTube in just a few minutes, and so that'll be hopefully helpful.
Okay, great. Yeah, and thanks for being so willing to share. It's like,
oh, of course, of course.
It's like so much easier.
Yes, I agree. I agree.
Okay. Well, thank you.
All right,
I know we'll be in touch.
A pleasure.
Okay.
We'll talk with you
Bye.
soon.
Alrighty.
Okay, bye.
Bye.